Hello and welcome to another box medicine tutorial, this time on hemorrhoids. Hemorrhoids are engorged vascular cushions of the anal canal, and in this tutorial I'm going to draw them for you. I'm going to tell you how we classify them, what symptoms they might cause and how we examine them. I'll mention the important investigations that might be indicated, and finally I will teach you how we can treat hemorrhoids, including some virtual whiteboard drawings to illustrate some of the surgical options. Here is a drawing of a coronal section through an anal canal that I often draw to help illustrate hemorrhoids to my patients. Here are the buttocks, the anal verge is over here, and this is the anal canal. This line that I've drawn denotes the dentate line, and it is important that you understand its significance. It lies about 1/3 of the way up the anal canal and denotes the change from squamous epithelium below, like that of the surrounding skin, to columnar epithelium above, like the rectal and colonic mucosa. It is not an invisible line, you should be able to see it. Now there are also differences above and below the dentate line in the vascular supply and lymphatic drainage of the anal canal, and also in the nerve supply. So anal canal above the line is not really sensitive to pain, whilst below it is very sensitive indeed, and we need to bear this in mind when we perform any surgical procedures in this area. Lining the anal canal is mucosa which forms anal cushions. These anal cushions are thought to be important in the fine-tuning of continence. At regular positions in the submucosa are hemorrhoidal vessels which feed these vascular cushions. So far this is all normal anatomy. When we talk about hemorrhoids, we refer to anal vascular cushions that are causing problems, generally because they are engorged and swollen. This can occur if the connective tissue inside the vascular cushions break down and fragment due to excessive downwards pressure, allowing excessive engorgement and also prolapse. There are 4 grades of hemorrhoids, and they all relate to the degree of prolapse. So with grade 1 hemorrhoids, there is no prolapse. Grade 2 hemorrhoids, prolapse but reduced spontaneously. Grade 3 hemorrhoids, prolapse but can be reduced only manually, while grade 4 hemorrhoids are prolapsed and are simply not reducible. Generally speaking, anything that increases filling and downward movement of these hemorrhoids is a risk factor for their development. So repeated straining due to constipation, defecating in the squatting position are examples of risk factors. Any cause of raised intra-abdominal pressure is also a risk factor, such as pregnancy. Finally, susceptibility to hemorrhoids may just be something that is handed down genetically. Now I hear you screaming, what about portal hypertension? The increased pressure in the portal venous system can lead to varices at sites of portosystemic communication, and one such place is the anal region. So portal venous hypertension may lead to varices at the anal canal, which are dilated tortuous veins, rather than hemorrhoids, which are swollen vascular cushions. This is really simple. Hemorrhoids may be asymptomatic, which means they are irrelevant and can be thought of as effectively being normal anal vascular cushions. If they are symptomatic, then the complaint may be one or a combination of anal pain, prolapse, so feeling a lump coming down from the anus, perianal itching, known to you and me as pruritus ani, of which there are a multitude of causes, and last but not least, rectal bleeding. With rectal bleeding, you need to know whether it is bright, so fresh, or dark, and also whether it is mixed or separate from the stool. Fresh bleeding is more typically hemorrhoidal, but if the blood is dark or mixed with the stool, then it suggests it may actually be coming from higher up in the GI tract. When you examine a patient, make sure you wash your hands, introduce yourself, gain consent, find a chaperone, and appropriately expose and position your patient.
When we're ready, a digital rectal examination always begins with inspection. Hemorrhoids may or may not be visible externally. Stretch out the perianal skin a little so that you can have a good look to see if there is an anal fissure. With prior warning and permission, lubricate a gloved finger and digitate the anal canal and make sure there is no palpable tumour. You can't really feel a hemorrhoid, so you need to have a look with a proctoscope. A proctoscope is essentially a transparent tube with a light source. Again, with prior warning and permission, lubricate it and gently insert it into the anal canal. Then withdraw it slowly and you may see hemorrhoidal cushions drop into the top of the proctoscope. A hemorrhoid may look quite inflamed and friable, or the mucosa may look quite unremarkable. Rigid sigmoidoscopy may also be worth doing to look for other causes of a patient's symptoms.
Remember that hemorrhoids are so common that just because somebody has them, it does not necessarily mean they are the cause of a patient's symptoms. Important differential diagnoses include a colonic tumour, which can cause rectal bleeding and or a change in bowel habit. Anal fissure is covered in a separate tutorial and typically causes painful defecation and fresh bleeding. Other differentials also include perianal abscess and perianal hematoma. This list is not exhaustive, but I hope this gets you thinking a bit more about other possible causes. I think that arguably the most important diagnosis not to miss is cancer. Here we consider investigating a patient's symptoms not to make the diagnosis of hemorrhoids per se, but to make sure we aren't missing one of our differentials, particularly colorectal cancer. So in young patients with a very low likelihood of colorectal cancer, you may decide not to perform any investigations at all, or you might request a flexible sigmoidoscopy to look at the last part of the large bowel from where bleeding may also appear fresh. However, you should consider full imaging of the colon either by colonoscopy or CT colonography when the risk of colorectal cancer is higher. So in slightly older patients, in patients who have darker rectal bleeding or rectal bleeding that's mixed with the stools, those with a change in bowel habit, or in those with a family history of colorectal cancer. Other investigations include MRI, which we can use to look for other causes of anal pain. Management of hemorrhoids is influenced first by the principle of trying to manage something without surgery in the first instance, secondly by the hemorrhoid classification we described earlier, thirdly by the size of the hemorrhoid, and finally, of course, what the patient wants. In general, conservative management is our first-line therapy for grade 1 hemorrhoids, which are the ones that don't prolapse and so are relatively small. Conservative management means giving good dietary advice together with stool softeners to help a patient avoid straining. You can also point them to over-the-counter creams to help soothe the hemorrhoid and reduce some of the symptoms. Grade 2 hemorrhoids are those that prolapse but spontaneously reduce, and these are suitable for sclerotherapy, rubber banding, or hemorrhoidal artery ligation, also known as transanal hemorrhoidal dearterialization. Let's take a look at what each of these therapies actually involve.
Here's our drawing again, this time showing a grade 2 hemorrhoid. Rubber banding involves the use of a suction device to suck up a bit of hemorrhoid near its pedicle and slipping a tight rubber band around it. The little nubbin of hemorrhoid eventually becomes necrotic and sloughs off, and the resultant scarred area does two things. First, it effectively restores anatomy by fixing the hemorrhoid up into the anal canal, and secondly, the scar serves to limit the vascular engorgement of the residual hemorrhoidal tissue. Be careful not to band below the dentate line, or it really can be very painful. Banding doesn't work all the time, but the advantage is that it can be performed in the outpatient clinic. Sclerotherapy is the injection of a sclerosing substance, for example phenol, into the hemorrhoidal pedicle. This causes a fibrotic reaction and again a scar is formed. The important thing here is to make sure that you don't inject into the wrong place, for example into the prostate. In terms of symptom resolution, banding and sclerotherapy are both effective around 2/3 of the time. Hemorrhoidal artery ligation, or transanal hemorrhoidal dearterialization, that's a bit of a mouthful, and this is where we ligate the blood supply going into the hemorrhoid to cause it to shrink down, sometimes with the help of a Doppler probe to find the vessels. It is a technique that is effective in resolving symptoms from a hemorrhoid in more than 90% of the time. Sometimes it can also be combined with a hemorrhoidectomy, where a suture is first used to ligate the vessels and then to lift the prolapsing mucosa back up into the anal canal.
Grade 3 hemorrhoids are the ones that prolapse and are manually reducible. These can be managed similarly to grade 2 hemorrhoids, and sometimes larger ones can be excised. This is called a hemorrhoidectomy and is also how we can treat grade 4 hemorrhoids, the ones that are prolapsed and irreducible.
Hemorrhoidectomy can be open, closed or stapled. Traditional open hemorrhoidectomy, also known as a Milligan-Morgan hemorrhoidectomy, is excising the hemorrhoid, being careful to avoid the anal sphincter and leaving an open wound to granulate and heal. Closed hemorrhoidectomy is where this open wound is, well, closed. Stapled hemorrhoidectomy is reserved for circumferential grade 4 hemorrhoids. In this procedure, a circular stapler is introduced and a rim corresponding to the tops of all the hemorrhoids is drawn into the device. The stapler is then fired and this redundant hemorrhoidal tissue is all excised, leaving behind a staple line that can then scar over. The hemorrhoids are thus lifted back up into the anal canal and reduced into a more anatomical position.
So that's how we manage hemorrhoids electively. What if someone presents acutely with a symptomatic hemorrhoid? Well, most of the time this can be managed conservatively, but occasionally emergency surgery is indicated. One example might include an acutely painful external hemorrhoid that is thrombosed, although even these can be left alone as they tend to get better with a bit of time. Emergency hemorrhoidectomy may be considered for one that has been heavily bleeding and is at risk of further massive hemorrhage, or an acutely painful prolapse hemorrhoid that will not reduce due to edema and anal spasm. The most frequent complications of surgery include pain, which may last for some weeks, particularly after open hemorrhoidectomy. Secondary hemorrhage may occur even after banding once the patient has returned home from clinic. Infection may actually manifest as bleeding after a hemorrhoidectomy. Sclerotherapy risks urological sepsis if the needle is inserted into the wrong place, although this is quite uncommon. Finally, anal stricture may affect a small number of patients following hemorrhoidectomy. I have to say, I don't think you need to know the details of the surgical management of hemorrhoids in order to get through your exams, but I believe that if you have tried to learn them by watching this tutorial, it might actually help you remember the basics. These basics are 1. That hemorrhoids are engorged and swollen anal vascular cushions. 2. They can cause pain, bleeding, prolapse and itching. 3. They can be examined using a proctoscope. 4. Conservative management involves advising on the steps to avoid constipation and straining. And finally 5. There are surgical procedures that range from sclerotherapy and banding to hemorrhoidal artery ligation and hemorrhoidectomy. I'm Danny and that was a box medicine tutorial on hemorrhoids. Now go and answer the multiple choice questions to test your knowledge at www.boxmedicine.com. Take care, bye bye.